Firstly, it is always a diagnosis of exclusion. That means when we see a patient who has low platelets, we need to make absolutely sure that it is an immune-mediated thrombocytopenia, that it isn't caused by something else.
Welcome to our special ITP in Kids series, part of the Beyond the Count podcast. This series is dedicated to children living with immune thrombocytopenia and the families who support them. We'll be exploring everything from diagnosis and treatment to school, sports and emotional well-being. We'll speak with leading ITP clinicians, hear from parents who've walked this path, and even chat with kids themselves, giving you a full 360-degree view of what life with ITP really looks like. Whether your child has just been diagnosed with ITP or you've been managing ITP for a while, this series is here to support you, inform you, and empower you every single step of the way. Today I'm joined by Associate Professor Dr. Tina Carter, Paediatric Haematologist at Perth Children's Hospital. In this episode, Tina shares her decades of experience in paediatric haematology, explains how doctors decide when treatment is needed, and walks us through the different options available. If you're a parent navigating ITP, this conversation offers practical insights into treatment decisions, side effects, and the importance of education and support. Let's get started. Okay, so we are talking about what are the treatment options when it comes to kids living with ITP. Today I have Dr. Tina Carter joining us to talk about all things kids living with ITP, and especially about what are the treatment options, including no treatment options as well. So Tina, thank you so much for joining us today.
Thank you, Danielle, for inviting me.
It's so good to have you here and joining us on Beyond the Count. And it was fabulous to see you in Perth just only a couple of weeks ago. God, it feels like only a couple of weeks ago, but it was God, it was more than a month ago now. So when you have a child come in, present with ITP, whether they're sort of newly diagnosed or have had ITP for a little while, when do you decide it's time to treat the ITP?
Well, that is a great question because it's a really hard question to answer sometimes. And I'll tell you a little bit by giving you a little bit of a background, I guess. I've been working now in paediatric haematology oncology for 30 years. Oh my gosh, but it is 30 years. And so I have witnessed some changes. And when I was a little registrar, we used to treat everybody in terms of pediatrics. When they came through the door, we gave them either steroids or IVIG, which is immunoglobulin, but often steroids. And that was the international approach for children pretty much then. Then we went through a phase, probably about 10 years or so, a phase of not treating patients who had ITP, because acknowledging that actually probably in most kids it's a benign condition when they first present, and that it gets better by itself regardless of what you do, and with a bit of reassurance to the family that it will get better, most kids do. And now I think the pendulum has swung again back a little bit into the middle of trying to work out who we should treat. So firstly, it is always a diagnosis of exclusion. And what does that mean? That means when we see a patient who has low platelets, we need to make absolutely sure that it is an immune-mediated thrombocytopenia, that it isn't caused by something else. So we have to make sure, first of all, that that kid, and we see children of all ages, 0 to 17, doesn't look unwell. You know, that's the big one, I think. They don't look unwell. They shouldn't really be pale, and they shouldn't have a fever, and the rash that they have, as you know, should be bruising and petechiae, those little spots, and nothing else. They might have some bleeding, and they might have some bleeding from their mouth or their nose, or they may have had some gastric bleeding of some sort or gut bleeding, but they shouldn't have significant bleeding. And if they do, that's a problem. They shouldn't have a headache. If they do, that's a problem. And they shouldn't be on any medications that might explain their low platelets. And also family history. Is there a family history of autoimmune diseases or something that might give us a clue that there's something else happening? And then when we examine, and we're looking at the kid all the time, do they look happy? Do they look irritable? Do they look like they're in pain? Are they looking sad? They might be sad because they're covered in bruises, but you shouldn't look unwell. You shouldn't look pale and sweaty, and your heart rate shouldn't be up. They shouldn't have a cough. They shouldn't have any signs that there's fluid in their lungs or anything untoward that would make us think there's something else. So this diagnosis of exclusion is what I spend my whole career making sure when I'm talking to families that's the case. And when we look at the blood film, we should see that it's just the platelets that are low. And they can be really low, as you know, they can be like 0 or 5. And in fact, strangely, that is much more in keeping with the immune-mediated transient disease than something that's, say, 50 or 60, which might sound better to the parents, but actually makes me think, oh, what else is happening here and how long have they had these platelets like this? So, and we make sure they're not anemic and their white cells are okay. Sometimes they can have a bit of anemia, as you know, and they could have a bit of iron deficiency anemia in the background because that's also not uncommon in kids anyway, so depending on their age. So we sort of must make sure the film gets looked at. I'm really lucky because I get to look at the films as well as the patient and talk to the parents, but also just make sure that a good morphologist has had a look and said, no, this looks like ITP, immune-mediated, there's nothing else. So they're the big things to start with. So if they're looking well and we can't find anything, and in terms of clinically that would make us suspicious, we may, and the parents, this is really important, are okay with that, we will provide them with our education list and we'll send them home and not treat them at the beginning. So that's at the beginning.
Yeah, and that's if they're not bleeding.
And that's if they're not bleeding. If they are bleeding, or they're a toddler running into the wall, adolescent who feels very much like, I don't like this, or parents who are really anxious, regardless of what we said, we may opt for some treatment because it might be it's just what they need there and then. It's like everything, it's education, and support. So as long as the parents and the kids feel that they have support and they know what to do, they know what to look for, they'll feel a bit better. No, I'm never going to make them feel 100% better.
No, that's not realistic.
But I'm going to try and make them feel like here is a plan for what to do, and here's who you contact when you need to.
Yeah.
Anytime, you know. I'll talk about the Rare Care Navigator service that we set up. Because this Rare Care Navigator service that Dr. Gareth set up for us in WA, we have the nurses from that service that actually, when someone's newly diagnosed with ITP, they provide an extra service on top of my haematology nurses and doctors. So they're someone, they go through everything again during the day with the parents. They go through the sort of, again, educate them about what ITP is, what to look for, what to worry about. The kids get this passport. It's it's an emergency presentation passport, which means as the parents are concerned, they go to ED, they can bypass the system because they can get to us more quickly. And it's really for newly diagnosed ITP. So it's not for a chronic ITP. So it's a really great service, Rare Navigator service, which works with us and just helps those parents, those kids navigate the system,
Well, and that's the hardest part, right? The guidelines, we have them readily available on our website. We hand them out like glitter. You can download them off the website as well, knowing that, that they are, really helpful for patients and really helpful for the parents of patients as well. So having those resources, because, once you become diagnosed with ITP, you become so highly educated as well. There's this fast, steep learning curve that you've actually got to navigate. And the amount of times that we've spoken to parents in the ED, their 7-year-old has had a head knock, no concussion, but really anxious because they don't know what's happening and, what do I do? Being able to support them through that, or say, okay, so which hospital are you in? And, who are you waiting to see? And have you reached out to your haematologist? Because when you're in the middle of that vortex, you're not thinking clearly. You're really not as a parent or as a patient. So having that support network is really important, but making sure you're accessing the really important resources is, really important. It's a chaotic journey. Because more often than not, a lot of these parents have never heard of ITP before.
No,
what?
Of course not.
Pardon, what?
Yeah. What? What's that? Are you sure? Like what?
What's that? Yeah. So it's quite confronting and challenging.
Thanks to our sponsor Sobi for their ongoing support of ITP Australia and New Zealand and our podcast Beyond the Count.
So going back to, to deciding to treat. So little Johnny presents, when is it time to actually start a particular treatment or go down that watch and wait sort of path?
And as you know, the treatment, the first level of treatment, first tier of treatment is steroids, and they're oral usually, and they have a lovely little array of side effects because they sort of work across the board. They're not what we call target specific. So they're not going to target exactly what we want. They'll sort of just dampen down the immune system. So the immune system is overreacting to some sort of provocation, usually a virus. It's making an antibody that's attacking the platelets as well as the virus it was meant to attack.
Yeah.
Or it's the T cells that are telling the B cells, these are our lymphocytes, to attack the platelets. Or sometimes the very beautiful megakaryocytes in the bone marrow, they're my favourite cells, by the way, they are being attacked as well. So it's not just the platelets. Okay, we're going to treat them. We're going to treat them with steroids. We know that there's a few things we'll learn. One, the numbers might not change too much, but the symptoms might actually change a lot.
Yeah.
So that's good, but it's going to take 12 hours to work.
Yeah. And the side effects there as well with steroids.
The side effects.
We call them Satan's Tic Tacs for a reason. Like it's... Yeah, that especially can you imagine an adolescent, already with all those complexities of, growing up and high school and body image and, all these other complexities. And then you add steroids to the mix. Moon face, weight gain, mood swings, all of the fun. Like you thought your teenager had mood swings, so put them on steroids and then give us a call. It's interesting. It's absolutely interesting.
That sleep disturbance in a 2-year-old, thank you very much, Dr. Tina. That's just what I wanted,
I'm up every night. Thanks so much.
But we do know that it is dependent a little bit on how long they're on them for. So if you can keep it for 5 to 7 days, and that's the sort of magic maybe number, depending on the dose. The increased dose can shorten the days but give you more side effects. The reduced dose can broaden the days, but then probably in the end just none of it really makes that much difference to the outcome of the disease unless it's going to be a bleeding ITP, and that's different, or it's going to persist and become chronic and then... And so I guess the other drug we use is intravenous immunoglobulin, and that sort of binds to the antibody and blocks their effect on the platelets and the megakaryocytes. But that too is
It doesn't have a long
it's
shelf life.
intravenous.
Yeah, it doesn't.
Yeah.
Imagine putting a 2-year-old with an IV and having to get them to sit still while the treatments they're experiencing the treatments, or even just trying to get the needle in, and the trauma that potentially can be caused. So there's all of these other contributing factors.
Sometimes we decide on intravenous immunoglobulin. I will, if I'm really looking at the kid and think, I'm not happy about you. I'm not quite convinced that you haven't got something else happening. And we don't want to start steroids because that might mask something else.
Yeah. It's challenging. Like, you've got to weigh up all of the risks and all of the, get all of that information and, make that shared decision together, because it has to be a mutually decided decision when it comes to treatments. So you've gone through first line treatments. Let's move into the second line treatments. These are the much newer agents compared to, I suppose, steroids and IVIG. But they've still been around for what? 10, 15 years?
Some of them have been around
20?
for like 20 years.
Yeah, like they've been around for quite a long time. So, you're looking at the newer agents, the second line treatments. So talk to us about those particular treatments.
Yeah, and again, I guess to emphasise again, most kids get better by themselves, don't need any treatment. And that is like 85% of kids.
It's a good chunk. It's a good chunk. Yeah, very good chunk.
Yeah. And when I say get better, they often get better within a few weeks, days sometimes, but mostly weeks, months, sometimes months, even pushing out towards a year, but their numbers gradually go up. So mostly they do really well. We don't have to do that, which is great. And then in a small percentage, they'll have this chronic ITP where it sort of just persists, is low enough, or they're having recurrent bleeds and we're not winning. And we have to use something else. And there are some different agents and they have different effects again, like everything. There are some beautiful new drugs that work directly on my friends, the megakaryocytes. So megakaryocytes are the factories in the bone marrow that make platelets. They're busy making platelets as much as they can, working really hard. They are so cute. And these drugs are oral agents and one is subcut, and they can actually make those megakaryocytes, they bind the receptor, make them make more platelets.
Yeah, put them on like supercharge.
Just going into the factory and saying, "Oh, you guys, you're going to have to work extra hours and make more platelets."
Like Santa's elves at Christmas, like they're on.
That's right.
No holds barred.
Get on. And the kids' bone marrows are amazing. So we're not talking about adults at all. We're talking about children. Children have really active, healthy bone marrows. They can pour out those platelets, but their immune system is equally as active, and they can kill those platelets as well.
Yep.
And their spleen is busy taking out the platelets that are covered in antibodies. So it's an interesting process. So these drugs are great, but again, they take a while to work.
Yeah.
And so one's oral, L-trombopag, and the other one, romiplostim. And then there's another beautiful one called avatrombopag, which is now we're allowed to use on kids.
We are.
And the L-trombopag is great. It's oral, but it's a nightmare with kids that are drinking milk or milk products, and that's a lot of our patients.
The dietary restrictions can be extremely challenging, so I do understand that. Yeah.
Yeah, avatrombopag isn't, but we're not allowed to use it up front just yet. And the romiplostim is great, but it's an injection once a week, and it too takes about 10 weeks to work.
And it takes time to adjust the dose as well to make sure that you're using it effectively. So, yeah.
We do a bone marrow usually in our institution before we start those drugs, mainly because, we want to absolutely, again, make double sure, triple sure, quadruple sure that they've not got something else causing this chronic ITP. The immune dysregulation that is ITP is incredibly complex, and we now can diagnose like genetic causes much more easily. So we do tend to work the kids up that have chronic ITP a lot more effectively. You know, we measure their immunoglobulins, we look at their immune function, we look at their bone marrow, and we do send off for molecular studies now to see if they've got a chronic sort of condition that's causing this. So I guess we do all that process, and they're the main drugs. There's another drug called rituximab, which parents usually run a mile from, but, you know, it is a very effective drug. If it works really well. You have to come in and have it once a week for usually about 6 weeks, 4 weeks, sorry, not 6 weeks, ignore me, 4 weeks. But it can be really effective, and it drops their B cells. It actually attacks the B cells, and they're the cells that can be producing the antibody. It can get better and then come back again after 6 months with the rituximab once the B cells start to recover. I'm usually very suspicious when that happens, that there isn't some genetic component to their disorder that's causing them to not quite, you know, have a transient ITP. And then there are some new drugs coming that are, again, supercharged.
So heavily targeted too. So through those some of those clinical trials and some of the new therapies that are coming through the pipeline look amazing.
Well, they, you know, some things that block what's called the complement system, which is part of your immune system, things that can block, again, these plasma cells, which are sort of long-lived B cells. And we think, well, they can be a bit of a problem because they're long-lived and they've got good, strong memories. And then there is the good old splenectomy, which, you know, again, we used to do it a lot more often. It began in the 1950s because they worked out some patients responded. We sort of slowed it down a bit. It's a lot more common in adults. We really try hard not to.
See, and that's the thing though too,
now.
right, is that not every treatment is going to work for every patient. It's not going to be effective. And this is part of the nuance when it comes to ITP is that not everything, there's no definitive path on this is how your ITP is going to travel. So if you do become chronic, now I'm chronic, I've been living with ITP for 10 years. I still live a very meaningful life. It doesn't mean that you can't. It's just a label. It's just a label that says, you've gone through 12 months. It doesn't mean there's anything else wrong with you or, all of these, and that you're definitely going to have this for the rest of your life, or doesn't mean it's just purely a label. But, splenectomy, it might be your thing. It might be the thing that puts you into remission. And that's the one thing that we need to remember is that all of these treatments are available. There might be one of those things that is your thing, or even in combination, there might be something that works well as well. Yeah.
And we all talk to each other. We are, especially in paediatrics, we're very good, but even the adults now, adult haematologists know that, we all collaborate and talk. So if we have a tricky patient, we talk across the country and across the countries,
globally. Yeah, definitely.
And also I tell my patients that, we're learning so much all the time. Things are getting better.
They really are. They really are.
I think that our treatments are getting better. Our understanding of, which patients might bleed, which patients might not bleed is better than it was. And so I think, take heart that we're getting better, in terms of how we treat these diseases generally, and that they might not have it for life. They may it might get cured. We might find the right, key for your lock.
That would be amazing. Yeah, exactly. What happens in the next 10, 20 years, we just don't know. We don't have that crystal ball. God, I would do anything for that crystal ball, but we don't have it. So we don't know. And because things are moving so very fast when it comes to, treatment options now, and even the research and the clinical research that's happening around platelet function and, all of those sorts of things, there's so many different things happening both locally and internationally. What is right today may be different for you later in the future, or you may not need it because you might be in remission as well. So, what we know in the future is vastly different to what we know today, and it's constantly changing and evolving.
I think the other thing, Danielle, is that I think because when you've done peds, you always, whatever you do in pediatrics, you're always dealing with the family. You always have the patient and then the parents, and so you're always working together to work out what's best for everybody. Like I think that it's one of my daughters said to me, "Oh, Mum, it's really very good holistic medicine, isn't it?" And I think, yeah, I think it is actually. I mean, nothing's perfect, but we always think, I'm always thinking about, that kid and that family and where do they live? Have they got a dog? Do they live they live
exactly.
near a farm? Are they, what do they do? They play, is soccer the most important thing in their lives? And if you stop soccer, is that going to really, the whole family are just going to fall apart?
Exactly. You just, you're tailoring, and taking everything into account. You're looking at the person, not just the platelet count. One day, I really hope that from an ITP perspective, diseases like globally, like I think that we need to be looking at the individual and treating the individual, not just the disease or the symptoms. And I think ITP has really, paved the way in that space. And it's to the people like yourself, Tina, that's really championed that. So thank you very much.
Well, I think also you've championed it. People like you sort of spreading that message and making people have discussion.
The one beautiful thing about the ITP community is that we are global and we work so well together. Thank you. I hope you all got a lot out of today's episode. Before we wrap up, here are 4 key takeaways from our conversation with Associate Professor Dr. Tina Carter. Number 1, not every child needs treatment right away. Many children with ITP improve on their own, and doctors often use a wait and watch approach if there's no significant bleeding. Number 2, treatment decisions depend on symptoms, not just the platelet count. Factors like bleeding, bruising, head trauma, and family anxiety all play a role in whether treatment is to be started. Number 3, several treatment options are now available for ITP. There's steroids, IVIG, and TPO agents can be used when needed, each with benefits and side effects that must be balanced with the patient and the family's quality of life. Number 4, education and support are critical. Parents and children need clear guidance on what to watch for, when to seek help, and reassurance that they're not alone in navigating ITP. Thank you to Associate Professor Dr. Tina Carter for joining us on this episode of Beyond the Count. We appreciate the time you've given to share your expertise and for the care and support you continue to provide children and ITP families. If you're looking for support, connection or information, visit itpanz.org.au. You'll find The Count, our quarterly magazine, patient stories, treatment information sheets, clinical guidelines and a wide range of resources designed to help you and your family feel informed and supported. Most importantly, you'll know that you're not alone. There's a whole community here just waiting for you. If this episode was helpful, please share it with others in the ITP community and leave us a review on your podcast platform. It helps more people find Beyond the Count. We've got more expert conversations, patient stories and more coming soon. So hit the follow or subscribe button to stay updated. Thanks for listening as we go beyond the count together.